right. So welcome everyone to our learning opportunity for this month, August 27th, 2018. We have two presentations from two of our members of our regional network that they're planning to present at the Safe States Alliance conference next week. And I thought it would be a good opportunity for them to share their presentations with our group since I know not everybody's able to attend. And we do have a few presentations going on next week. So I thought it would be a good opportunity to hear what other people within our region are working on. We'll start off with introductions. So if you could just introduce yourself and your role in your organization, and then we'll get started with the presentations. And I'll go through the list of participants, and when I announce you can introduce yourself. But I will start. I'm Colleen Kapsamalis. I work in the Violence and Injury Prevention Mental Health Promotion branch at the Colorado State Health Department, and help to facilitate the regional network coordinating organization for states within our regions 7 and 8. So just going down the list, Felice, could you introduce yourself?
Sure. My name is Felice.
It's hard to hear you, Felice. I know that with the computer closed, I think it's hard. Can't hear you, sorry.
Sorry, keep moving.
The other option is if you call into it instead of using your computer audio, that might work better. And we can come back to you if you'd like. So we'll come back to Felice. And Tracy, could you introduce yourself? Are you there, Tracy?
Can you hear me?
Yes, now we can.
Okay, sorry about that.
Okay.
I'm Tracy Hardy. I am the project officer for Colorado. So excited to be here that I called in at 3 o'clock looking at it, and it was actually 4 o'clock Atlanta time. So
sorry about that.
No, that's my own fault. I was just so excited to be here. So.
Okay, well, glad this time worked for you too. Thanks, Tracy.
Yes.
How about Kate, if you would mind introducing yourself?
Yeah, can you hear me?
Yes.
Great. My name is Kate. I am a community outreach specialist with the Violence and Injury Prevention Mental Health Promotion branch at the Colorado Department of Public Health. And Colleen, just so you know, the 201 number is mine.
Oh, okay. Thanks for the heads up.
Yeah.
And then Jeannie.
Jeannie Beets with the Nebraska Department of Health and Human Services Injury Prevention Program, and I'm the Motor Vehicle Safety Coordinator.
Thanks, Jeannie. Thanks for joining. And then Sarah and Michael, I may have you wait to introduce yourselves until our presentations, if that's okay.
Sure.
Okay. And then let's see. Michael, I know you're on the phone. Are you the 801 number or 402?
I'm the 801.
Okay. And then who is that 402-730-0106?
That's me, Jeannie.
Okay. Okay. Thanks. Yeah, it's.
I don't know. I'm like showing up twice.
Yeah, I think when you call in and use the computer, if you don't use audio for the computer, just listen twice. But that is.
Okay. Yep. That's me.
Okay. And then Felice chatted and said she was using a headset and thought it would work, but Felice is an evaluator here at the Colorado State.
Oh, I called in.
Oh, okay.
Hi. Yes, thank you. Hi, my name is Felice Senior, and I have the best luck with my laptop and my headset, clearly. And I'm a violence and injury prevention evaluator, and I work for the Colorado Department of Public Health and Environment.
Thanks, Felice. I think I got everyone that's listed. So thanks everybody for joining the small group today, which hopefully will be good for a good discussion. So as I mentioned before, we are gonna hear from two of our members about the work that they're doing in their states and what they'll be presenting on during the Safe States Conference next week. So Michael Staley is from the Utah Office of the Medical Examiner. And Michael, if you wouldn't mind introducing your role there and what you work on, and then feel free to dive in and talk about your project.
Sure. So, yeah, my name is Michael Staley, and I'm at the Utah Office of the Medical Examiner. We're part of the Utah Department of Health. My role is I wear many different hats, I suppose. I'm the psychological autopsy examiner here and also the suicide prevention research coordinator. Those two, of course, fit very nicely together. And most of what I do is related to understanding suicide deaths and then compiling all of that information for purposes of research so that we can inform our prevention efforts better. I also do investigations here when a medical examiner needs more information or a family appeals our decision of a suicide. Then I can get involved and try to build the most comprehensive psychosocial medical history of the decedent that possible, and just create a more informed decision for the medical examiner that makes that call. I think I'll leave it there for now.
Okay, thanks. Do you want to talk about what you're going to be presenting at the Safe States Conference and next week about the community response, or?
Sure. You want me to just go ahead and give my little spiel?
Yeah, that would be great.
Okay. Well, I wrote this out, so I apologize for the storybook feel. But if you have questions or somebody wants to chime in, by all means, please interrupt me. So, and I also want to preface this by saying that I am finishing my PhD in sociology from the University of New Hampshire, and they don't teach you this stuff in PhD school or Master of Public Health school, at least not in this specific way. And so when I was, in the middle of this or just getting started with this and realizing that I had to be the point person for this response, I'm contacting the state epidemiologist here in Utah, and she's saying like, well, she's kind of shrugging her shoulders as much as I am, and we're both sort of leaning into the answers. And this whole process really has been about leaning into those answers. And so this wasn't perfect, but this is our experience, and we're learning from it, and hopefully maybe others will be able to as well. So on March 30th, 2018, I called an emergency meeting with public health officials from the Utah Department of Health, the Utah Division of Substance Abuse and Mental Health, Salt Lake County Health Department, the State Board of Education, and Jordan School District after the 5th student at Harriman High School died by suicide. We hastily gathered that afternoon to develop a plan for high school and a community that had exhausted its resources and that families were living in fear, responding, and we were hopefully developing a response that could prevent future harmful messaging, national news stories, etc. I must mention that what I'm talking about today is still an active and ongoing investigation. So while I'll detail the plans for the epidemiological investigation part of this response, I'm not going to discuss any of the preliminary findings from these deaths. I expect that we will wrap up the investigation sometime before November or so, barring, I very much hope with every fiber of my being that there will be no further deaths in the suicide cluster, but I hope to issue a report before the end of the year. So the suicide cluster event highlighted the need for postvention planning on state, community, school district, and school levels. And I must say, when I sounded the alarms, partners came to the table with all of their resources and were dedicated to preventing further suicides, as well as providing services to their communities. Our response was far from perfect, and I'll discuss some of those problems later in this talk, but I would be remiss if I didn't say that we did a darn good job of responding to a community and school in crisis. Our response had 3 major domains. First, crisis and ongoing mental health support. Second, media response. And third, epidemiological investigation. Each of these domains was chaired by someone who was qualified or had significant experience in their subject area, and the entire response was coordinated by me. Although in future responses, I hope that we have a little bit better of a plan, a better response system in place, so that I will only lead the epidemiological response and not coordinate that large overall response. The crisis response. So perhaps the largest part of any response when we're talking about suicide is that, and in terms of human capital, what it takes to respond is that crisis response. And that includes not just a crisis response team. I think that's what we think of when we think of crisis response, but that includes the army of people that are working outside of that at hospitals, mental health centers, et cetera. And so I'm going to break down a picture for you of what was already in place when we gathered on March 30th. So keep in mind that Harriman High School and Jordan School District had responded to 4 deaths, one of the 5 deaths occurring the summer prior when we became involved in this response. We are still trying to get a better picture of what that response looked like, but what we do know is that it overwhelmed their school counseling staff. Of their 8 full-time staff and 1 full-time intern, 4 of them resigned their positions after the conclusion of the 2018 academic year. Jordan School District has a family counseling center staffed with 2 psychologists, in addition to 1 part-time psychologist that was available in the school and was referring students and parents to their counseling center. Additionally, Jordan School District had a crisis response team in place, but it became quickly apparent to us that this group were not trained for and were ill prepared to deal with a suicide cluster. It's fair to say that at the time that we formulated a comprehensive response on March 30th, Harriman High School and Jordan School District's response was rather limited in scope and frankly incorporated some practices that we believe could have been harmful, such as announcing student deaths over the school intercom and perhaps some inappropriate memorialization of students who died from suicide and other causes. And I bring that up not to call Jordan School District or Harriman High School out, but to highlight the importance of planning and accountability in that planning when we move forward. I believe that everyone, genuinely, from the teachers in the classrooms to the principals to mental health providers, were all responding in a way that they thought was best and most helpful. Everyone believed that they were doing the right thing, even when those things fell outside of the boundaries of best practices. 3 individuals coordinated the crisis response for Harriman High School: the Director of Psychological Services for Jordan School District, the Suicide Prevention Specialist from the Utah State Board of Education, and the Suicide Prevention Coordinator from the Division of Substance Abuse and Mental Health. We call it DSAMA here in Utah. These individuals could organize resources from across their school districts, throughout Salt Lake County and in other school districts, and the State Board of Education, and perhaps most importantly, from the mental health perspective, crisis workers from the local mental health authorities. Although Jordan School District began spring break the week after we formulated our response, we were still able to station crisis workers at Harriman High School during spring break. And for the most part, these crisis workers were underutilized. Not a lot of people came to the school during spring break seeking help. But we kept a presence at Harriman High School throughout that week, and we ramped up our response again the following week when students returned back from break. One of the biggest challenges was finding a physical place to put crisis counselors. With some finagling and adjustments throughout the day, crisis workers were able to see students in various places throughout the high school. And by that, I mean, we were using janitors' closets. We were using classrooms where the teacher was on preparatory period. Any space that could be private, we were using. At the same time that we were placing crisis workers in the school, the divisions of substance abuse and mental health was also able to broker relationships with other mental health care facilities and hospitals so that an individual could go in after hours and say that they were from Harriman High, and they would be seen, no questions asked, and be seen with expediency. In early May, I received notification that another Harriman High School student had died by suicide. Before the body had even been recovered, I was able to activate the already existing group of mental health workers so that crisis workers could be present at Harriman High School the following morning before students even arrived. Perhaps our best response was our last, which both saddens me and it also gives me hope that we actually were improving what we were doing. Mental health emergencies are difficult to see. There is no building on fire. There are no bodies in open water with helicopters hovering above. I feel that mental health emergencies are like freight trains coming down from a mountain pass with no brakes. On the occasion of this most recent death, I was frantically trying to assemble the response team and trying to think about what to do next. In those moments, I was forced to reconcile with the fact that mental health emergencies like this one were not created overnight, nor could they be ended or solved overnight either. We were then, and still are, responding. The next domain I want to address is our media response. In other responses I've read about, the media response is most likely to be downplayed or completely overlooked. And yet I think, and have the experience and data to back it up now, that communicating with the media is critical, and maybe even as critical as the crisis response workers that we put on the ground. On March 30th, that initial day that we gathered, we were aware that several local news media outlets were preparing to run stories the following day or within the couple of days following on suicide at Harriman High School. Several of us had already communicated with these new news media outlets, and the calls and emails were stacking up. Importantly, I and the suicide prevention coordinator at DeSama had a good relationship with most of the news media outlets here in Salt Lake City. We were in a good position to be proactive to shape the message. Additionally, we had conducted media trainings months earlier at which most news outlets had a representative. And I really believe that because of that training, many of the news media outlets were sensitive to the fact that one bad story shared 1,000 times on social media could cause irreparable harm. At our gathering on March 30th, every agency had a public information officer or PIO present. I cannot stress this enough. This is something we did right. We unified our message, agreed that we would share some details, but not others. Unfortunately, Jordan School District, under pressure from the media, released a statement before our meeting earlier that day that enumerated the number of deaths. As a group that day, however, we decided that because we were unsure if we were dealing with a problem specific to Harriman High School, Jordan School District, or something else, that we did not want to enumerate publicly the number of deaths that we were going to be studying or that could be part of this cluster. In addition to not knowing the scope of the problem, we did not also want to create a potential situation where students were thinking themselves as part of a death count. For example, in the late 1990s, the Golden Gate Bridge somehow leaked the fact that the 999th person had just jumped. It was actually the 999th body had been found. Many people jump and are not found and are therefore not counted. Local newspapers picked up on the story, and a local DJ offered to give a case of Snapple to the family of the 1,000th jumper. 20 years earlier, the same thing had happened with the 500th jumper, and that was when the t-shirt thing took place. Some people might have heard of the Golden Gate t-shirt incident. Someone ran onto the bridge with a t-shirt reading, "I'm number 500," and was taken to a hospital. In our response, we were very concerned that releasing the number of deaths, even at what we believed it to be, could add fuel to a crisis that was already burning white hot. Because we are and not yet done investigating these deaths, we are still not officially releasing a death count or in the suicide cluster. When that most recent death occurred, national media became interested in the story, and before we were even aware of their interest, we were notified that a Wall Street Journal reporter had already contacted several of the victims' families and had interviewed some of them. So while we had good relationships with local media, we still fear that national news outlets will release stories that are damaging to the Harriman community and school. In all of this tragedy, it's easy to point fingers at the high school, the school district, the county health department, the local mental health authority, me, any number of entities. But we focused our message in a forward-looking way. We wanted the people of Harriman, Salt Lake County, and the state of Utah to know that what they could do right now to prevent future suicides, and where they could go if they were having suicidal thoughts. We made a very deliberate attempt to keep the message on what we were doing to respond and not the imminent tragedy that we were responding to. And here again, that's what we did right. We stayed on message. We kept everyone at the table where we needed them. This response would have been significantly impaired if the school district had turned the state response away or if one of the state agencies bowed out. I also want to just address social media here, which is a major problem and a major boon to our response. Perhaps you've heard of the Serenity Prayer. You know, God grant me the serenity to accept the things I cannot change. Well, it took some major overcoming for me to realize that I had no control over the Twitterverse, Facebook, Instagram, Snapchat. And that was really hard, frankly. I wanted so badly to stay up all night, every night, responding to all of the horrible vitriol that was literally flowing out on these sites. But I could not, and I just had to turn it off. That was really hard. Our media working group did, however, create several posts that were intended to be shared and reshared in response to this crisis. Certainly, how we use social media and interact on social media as a health department is one that we're still trying to figure out. At the same time, we were able to communicate with a huge number of people via social media regarding resources that were available to them that we would have otherwise had no voice. I think many, if not most people, view social media as both a problem and a solution, and this situation only highlighted that tension. I'm moving now onto our epidemiological response, which is the one most familiar to me because it's my domain of expertise. So when 1 or 2, maybe even 3 people test positive for E. coli, county health departments, state health departments too, launch an epidemiological investigation to locate the vector and source of that outbreak in order to prevent further incidents. An epidemiological response to mental health emergencies, however, tends to be the ugly stepchildren of epidemiology. We don't wear respirators, gloves, full-body Tyvek suits, and the thing we are attempting to locate is often social, psychological, or otherwise difficult to find. But we do have tools available to us to point us in the right direction. Let me paint the picture of what resources we had available, which we realize may give us an advantage that other states, counties, or rural places would not have. First, the state of Utah has a centralized medical examiner system. If someone dies anywhere within the state, the Utah Office of the Medical Examiner assumes jurisdiction of the body as well as the investigation of that death. Further, I'm a full-time suicidologist in the Office of the Medical Examiner. I can and do have the ability to conduct investigations of suicide deaths or suspected suicide deaths at my discretion. My position relative to suicide deaths also means that I am able to track deaths in a specific place, geographic or social. Therefore, as long as I'm surveilling and give an indicator, I can have an active crisis response in place quickly and in a targeted way, or at least that's how it's supposed to work in theory. Additionally, because the Office of the Medical Examiner is part of the Department of Health, I have access to their epidemiologists and staff as well, which proved invaluable in this situation. Salt Lake County is also a metropolitan area, and as such, their county health department had an epidemiological staff as well as a violence and injury prevention staff that were also available in this response. On March 30th, we formed a multi-level case definition following the concentric circles model of epidemiological investigation. We used maps created by the epidemiologist at the Utah Department of Health to determine the scope of the investigation. The first of the concentric definitions was that the decedent had to have died by suicide after June 30th, 2017, was between the ages of 10 to 19 years old, and attended Harriman High School. Moving just a little bit further out, the second concentric circle expanded that definition to any person who lived in Jordan School District and also fell within that first concentric circle. And the third and final concentric circle expanded that definition to any person who lived outside of Jordan School District but attended school within the district, or vice versa, somebody who lived in the district but attended school outside of the district. We then set about conducting psychological autopsies of each of the decedents who fell in that first concentric case definition, which includes 8 cases, one of which was removed from the case set due to the loss of follow-up. I'm currently in the middle of these psychological autopsy interviews, which they take a huge amount of time to complete. Perhaps the most difficult part of this process is gaining access to these informants. Many of them are minors, which adds a level of complexity regarding consent. Because of the sensitive nature of the investigation, I'm not able to discuss preliminary findings, but like I said, I hope to have a report out before the end of the year. We kept our entire working group apprised of updates via conference calls that, following that March 30th response activation, occurred 3 times weekly. Then we moved to once per week, and now we're only calling these meetings when we have new information. I want to turn the page a little bit and now address some of the things that I wish had gone differently, and the things that we're going to do differently in the future should another suicide cluster in a school come to pass. First and foremost, there was no and is no established plan to address suicide clusters or even multiple suicide deaths that do not constitute a cluster. The Utah Suicide Prevention Coalition, which encompasses many of these state partners and local community partners, has identified post-prevention after a suicide as a major initiative in the 2018-2019 school year cycle, both in schools and communities. We need plans for both of those places. If in this situation we had a plan, we would have had crisis networks in place. The message that we would communicate to the media would already be in template form, and the epidemiological investigation would be at least partially mapped out. Perhaps the entity that would have benefited the most from the plan or having a plan is Harriman High School and Jordan School District. Having a plan in place would have outlined what services could be imported into that school and district, how to communicate with students, parents, and the media, among other steps in following a suicide in a school. Second, I wish that I would have initiated this response sooner. As part of our existing death investigation protocol, we did not routinely collect information regarding education, such as where that decedent attended school. Moving forward, we are tracking that information, and that will allow us to respond to these potentially contagious events more promptly. Third, while we had a great deal of coordination between state and local agencies, the cracks in those relationships were highlighted in this response. For example, the State Board of Education, even though they were part of our response group, took some actions that the rest of the group was not aware of and ultimately caused considerable confusion on the ground in the high school among staff and administrators. Having a plan would outline which agency and organization would be responsible for various items, and we would have avoided this type of conflict. Fourth, when I called the emergency response on March 30th, I made the deliberate response to exclude Harriman High School administration and communicate to them through Jordan School District administrators. I think the mistake in retrospect is obvious, at least to me, but I did that because I wasn't sure if the administrators had the ability to respond at this point, as well as I suspected that the problem might have been bigger than Harriman High School. In retrospect, of course, I wish that I would have included Harriman High School at the table starting from that first day. I now realize that having more partners around the table is not such a bad thing. I wanted to keep it small that first day, even though it ended up being quite large anyway. But having that expanded group at the table wouldn't have been a bad thing, as long as those partners have a reason for being at the table. I wouldn't want the media there, for example. Finally, I would be remiss if I didn't talk about the community response, and this is something that went right. These are those things that happened in response to the suicide cluster that were outside of the scope of work for the suicide response team. A community organization came about in the midst of all of this, mostly consisting of concerned parents. They ended up hosting a parent night that was very well attended. 450 plus parents were there. Jordan School District hosted a talk on suicide prevention for parents as well. Police agencies have become involved and are doing more community outreach. Churches from all across the community and county are hosting suicide prevention training events. Truth be told, I don't even have a full scope of everything that happened or is happening, but this tragedy really has sparked this community to act. Finally, and I think this is an important one for us moving forward, Jordan School District has changed the way that they engage in suicide prevention, including expanding mental health services and engaging students earlier. Of course, the outcome of that effort, because it's new and is unfurling right now as school is coming back into session has yet to be seen, but I'm very hopeful about that. So I'm going to end here, but just say that this is an experience that I will think about probably well into my retirement, some 50 years from now. And with all my heart and with all my mind, I genuinely hope that this tragedy, that this suicide cluster is defined and behind us. But it is something that keeps me up at night. I think about what will happen if another student from Harriman High School dies by suicide. And I know that we're better positioned now than we were even just a few months ago to respond to a death in this way. But we still have a considerable amount of work ahead of us. And I have a lot more gray hair than I did in February, that's for sure. So I'm not sure how we're going to do this, but I'm definitely able to answer questions if there are any.
Thanks so much, Michael, for walking us through the different domains of the suicide community response in those two school districts. We have a couple minutes for questions. Does anybody have any? Feel free to speak up if you do. I have one that I jotted down, actually, Michael. I know that you touched a little bit on the suicide prevention that's now happening in the school districts, but I was curious if there's anything that that related to suicide prevention that is going to be applied to other school districts in the state of Utah, just based on this process and this experience that you're aware of.
Yeah. Well, I'm unsure about the structure of this in other states, but in Utah, we have a suicide prevention specialist that's a full-time employee within the Utah State Board of Education. And so she is active in going out to high schools and middle schools and some elementary schools even, and doing these trainings. But I think looking forward for this at least coming year, we really want schools to develop good post-prevention plans and practice them. That's all about creating, it forces school districts to create these relationships with their health departments and mental health authorities that they need. And that's true of what happened in Jordan School District. And those relationships didn't really exist before this. And unfortunately, they were created under duress. Ideally, moving forward, those relationships will be forged well ahead of the time that they're needed, if they're ever needed at all. But that is really a huge area that's overlooked that we're zoning in on. And it has to be said that good post-prevention is good prevention. And so, in this instance, I don't know that had we responded after the second death or even the first death at Harriman High School, that things would have been different. Hindsight's 20/20, of course, but we definitely needed a response earlier and a more coordinated response.
Okay, thank you. Are there any other questions for Michael before we move on? Okay, well, thank you so much, Michael, for sharing with us on the call today, and I look forward to meeting you hopefully in person next week at Safe States.
And
Cool,
Colleen,
thanks.
a question just came in on the chat from.
My chat is not. Let's see.
She just said, can he come back and provide results?
Oh yeah. So Michael, there's a question on the chat that just Tracy Hardy from CDC was asking about maybe coming back and doing another presentation on results. Maybe specifically, is that specific, Tracy, to the psychological autopsies that he's going to be doing? Or something else?
Yeah, I would be happy to do that.
Okay.
We're talking about 8 deaths. So we're, of course, this is a small number, but I would absolutely be happy to do that.
Yeah, thank you so much.
I guess relatively 8 is a lot, but
Right. Yeah, that would be great to just hear more about what comes out of the psychological autopsies. Okay,
Sure.
Thanks, Sarah, for pointing that out too. We missed that. Okay, well, Sarah is up next. She's going to be, and I'll let you introduce yourself, Sarah, too, because I didn't have you do it earlier, but she'll be talking about the evaluation of Colorado's Essentials for Childhood project. And I will stop sharing my screen so you can share yours.
Okay, let me get that going first.
Yeah.
While Colleen's turning hers off, I'm Sarah Brand-Spiegel. I work at the Colorado School of Public Health. I'm with the University of Colorado. And let's see if I can pull these slides up. How does that look?
It looks good. Thanks.
You see the slides? Okay, great.
Yeah.
You never know for sure if they're showing the way they should be. So I'm going to talk today about the evaluation that we did as the partners for evaluation in Colorado on the Essentials for Childhood project, which was a statewide collective impact case study. And I'll be presenting this at Safe States next week, but it's on behalf of a team. Marissa Mora is a graduate student here in the Colorado School of Public Health. Carol Runyon, who's on the call today, professor here, and Tommy Cool. I don't know how to say her last name. I should know that, Colleen. But she is at the State Health Department here and was the lead for the Essentials project. So just quickly, I'll be talking about the project background. So for those of you who aren't familiar with Essentials for Childhood, a little bit more about that project, what methods we used for evaluation, the results and recommendations, and then some next steps for this work here in Colorado. So the Essentials for Childhood framework was put out by CDC in 2014, and it focuses on a primary prevention approach to child maltreatment that is looking at upstream factors to create safe, stable, nurturing relationships and environments for children. 5 states were funded to do the Essentials for Childhood work to kind of implement this framework: California, Colorado, Massachusetts, North Carolina, and Washington. And all the states were required to utilize a collective impact approach and to use a developmental evaluation approach, which is a little different than other evaluations that we've done. And it's a method that's designed for programs that are kind of unfolding in more of a collective impact way, so not as linear as a traditional evaluation. And so in Colorado, this was a 5-year project. The backbone organizations were the Colorado Department of Public Health and Environment, and then the Colorado Department of Human Services. And in the framework of collective impact, it was really about bringing people together in a structured way to achieve social change. So kind of the idea being that as a group, we're more than the sum of our parts, and that we can do more if we bring all the stakeholders and partners together to look at a systems level approach to making change to address the health problem. So the leadership in Colorado, as I said, was the Health Department and the Department of Human Services, which has an Office of Early Childhood that includes a focus on child maltreatment prevention specifically. And then there was a leadership action team formed for the Essentials project that had representatives from different state agencies, from the business sector, from nonprofits, from other groups as well. And then the project was staffed with a principal investigator, a project manager, and a project coordinator. There was some change throughout the project period, but generally it was about 2 to 3 people at the health department who were really staffing and leading the project. And every state had some flexibility in how they implemented the Essentials framework. And so the way that it looked here is 4 work groups were formed on 4 priority areas that were defined by the leadership team. So these are, again, these upstream factors that we think will create safe, stable, and nurturing relationships for children and thus prevent child maltreatment, preschool, access to preschool and full-day kindergarten, quality childcare and after-school programs, family-friendly employment practices, and social and emotional wellness, which this group was initially formed around this idea of sort of mental health and social and emotional health, and then it shifted a bit to be more about social norms related to caregiving and parenting. And there's a fair amount of evidence base for how these things relate to child maltreatment prevention. So this is where the group arrived as these should be the priority areas. And so for our evaluation, we were really looking at how to understand the project's development, the challenges, the successes, with the ultimate goal of developing recommendations for other collective impact initiatives. So we went about this with the idea of if another state wanted to pursue a similar path, what could they learn from how things unfolded here in Colorado? The evaluation design was through key informant interviews, so qualitative interviews, 16 open-ended questions. There was an interview guide that was developed in coordination with the project leadership. And 2 of the questions addressed success. Most of the questions were more about what are the lessons learned, what could have gone differently, what were the challenges, and so they were more related to critical feedback. And then these transcripts were all coded using NVivo 12, which is a qualitative analysis software. And as we looked at the results, we wanted to really ground them in the literature around collective impact. So according to this sort of seminal paper from the Stanford Social Innovation Review on collective impact, there are 5 conditions that are critical for success in this area. So having backbone support, a common agenda, mutually reinforcing activities, shared measurement, and continuous communication. So we looked at how these aligned with the project here in Colorado. 28 people were invited for interviews and 26 participated of those. And the interviews were conducted with project staff, leadership team members, project partners, and also our funders at CDC. And so the results, here's a bit about what we learned. In terms of success, the priority that we often heard cited as the biggest success of the program was that priority for family-friendly employment practices. So this was looking at things like employers providing parental leave, a living wage, health benefits, flex time, a whole suite of things related to being family-friendly. And this came up often as an area that really no one else in the state was sort of looking at in such a cohesive way. So it was like a niche area that this project could really grow into. And there was a real commitment to sustainability amongst the partners as well, that this is something we want to continue beyond the Essentials project. In terms of the development of the project, some of the things we heard were that squishy, fuzzy, EFC was a little squishy and hard to define, hard to evaluate, hard to communicate. And also that our ultimate goal was too fuzzy to be able to really direct our efforts. And I think some of this grows out of a collective impact approach, which again is less of a linear project and more of an evolving group of people trying to work towards a common goal. We heard about resources, that the limited funding, staffing, and a relatively short time span really constrained the capacity of the project. In terms of vision, the project struggled to define clear purpose and vision. And also that there was a challenge of effectively collaborating with other initiatives developing in Colorado. So at the time Essentials was beginning in Colorado, there were a lot of other initiatives like Project Launch and other things that were related to early childhood topics, things that were very much relevant to this work, but all these different efforts were kind of, I think, struggling to figure out how they fit together. Communication, we heard internal and external communication challenges. Some challenges with the clarity of stakeholder roles, and also a shifting structure and shifting distinction of roles in terms of staff leadership, work groups, etc. For backbone capacity, this is probably familiar to all of you working in state health departments, but limited autonomy of state agencies to really work on policy. So we know policy is important, but it's always challenging to figure out how to move the needle in a state agency. And then also collective impact, one quote here, I don't know that it felt like collective impact. I know it is collective impact. I hear that it's a collective impact project. I don't know that it felt that way. And then with our evaluation, some of the challenges that came up were evaluating a project that didn't have a clear linear strategy. Because of that, we focused on a process evaluation. And then there was sticky issues with evaluation team being participants and observers, sort of wearing both hats, which is a part of developmental evaluation, but can sometimes, I think, be confusing to others, saying, okay, are you an evaluator right now, or are you a participant? What's your role? So some of the recommendations grouped by theme here, I won't go through all of them, but some of the key ones would be learning the pre-existing landscape. If another state were to implement a project like this, really have a good handle on what's happening, what are the other efforts, and how to fit the pieces together. Infusing the work into other initiatives to enhance sustainability. Resources are always more limited than we would like, and so how to maximize that. And for vision, to engage in effective strategic planning, to start out with a very clear vision. And then also building intentional relationships with those doing related work, and developing and maintaining a communication plan, which is something that there was some effort to do here in Colorado. It never kind of fully gelled, and I think some of the communication challenges may have been well served by having more of a plan in the beginning. Quickly, a few other recommendations: clearly defining the stakeholder roles for effective engagement. For project structure, being very explicit about what the structure is and the process for leadership. And then being realistic about those constraints related to resources, policy making, other constraints that agencies face. Ensuring the effort feels collective, which can really take a lot of effort to do that, to make sure that partners are engaged and see their role. And then for the evaluation, I think our recommendation for other states would be to really align on some specific objectives that are measurable. So next steps, there's a new CDC funding opportunity for kind of continuing the work of Essentials for Childhood. And that funding opportunity really focused on two priorities selected by Colorado, the two that rose to the top here being the family-friendly employment work and the social norms around caregiving. And so we see that as really positive, that that's kind of going to continue through CDC's funding. Commitment from partners. We see a lot of commitment here to continue the family-friendly employment and the community norms work, and they've found some other homes so that they will be sustainable. And then also ongoing efforts are underway to secure new funding. And I just want to quickly acknowledge everyone who participated in the interviews, and Dr. Greg Tung here at the School of Public Health, who assisted us with the qualitative approach. So that's it. Any questions?
Thanks, Sarah. Are there any questions for Sarah about the evaluation of Essentials in Colorado? Oh, Carol, it looks like you might be talking, but you're muted, maybe.
I can ask one.
Okay.
Even though I was a participant in the evaluation, I'm wondering, Sarah, if you have thoughts about, if another group, or if we were to do this evaluation again, are there any things you could think of that you would want to do differently?
If we were to do this evaluation again, yeah, I think, it's a good question. I think being really focused at the outset about, I mean, we took a process evaluation approach, as you know, which has pluses and minuses. And I think there was always a tension about wanting to do more outcomes measures, but not being clear what those outcomes would be because the project was still unfolding. So I would suggest if we were to do that again or another state were to do it, to think hard about, are there some measurable outcomes that you could build in from the outset. So I think that it's always nice to have more than process measures.
Thanks. Are there other questions for Sarah? Well, I will share that we recently found out that Colorado is funded to do another 5 years of Essentials for Childhood, focused on, as Sarah said, the family-friendly strategies or economic security as well as social norms. And I think that there definitely was more of a focus in the funding opportunity from CDC to do more outcome evaluation. So maybe that's something that they learned also from the last 5 years. And then, Anne, I hope it's okay to announce this, but Utah is also a recipient of the Essentials Grant for the next 5 years. So they're a new state. Anne, I don't know if you want to talk about, if you can, about a little bit about the project it's going to look like in Utah, but it could be an opportunity in the future for some more sharing across our region around how we're doing this work. Similarly or different.
Hi, yeah. So thank you. Sorry, I was on mute. So our intentional injury team put together the application. So I'm just learning a little bit more about what that entails, but we're really excited about it and hope that there will be an opportunity to collaborate with other states.
Yeah, great. And I know North Carolina is the recipient again, and I actually am not sure who the other two states are. So so we'll find out as that gets rolled out. I think starting in September actually, so next week. Well, thank you so much, Sarah, for presenting. As someone who's been involved a little bit in the process, it was nice to hear the results too. So thanks for sharing that. Okay, so just a little bit of wrap up in our final minutes here. I'm going to try and share my screen again, hopefully. Okay, so our next learning opportunity or meeting, I should say, is actually our annual in-person meeting, and that's going to be at the Safe States Conference next week. I know not everybody can attend, and there is a survey that I've sent out. Thank you for those who have taken it. We actually have a good number of people that are able to attend in person, which is really nice. But if those of you who cannot attend and are interested in calling in using Zoom, a Zoom link or something like that, we can definitely set that up. So I'm just trying to get a sense of if anybody's interested in that. I haven't checked the survey results in a couple days, so I'll take a look. But I just plugged the link into the chat box, and I would love it if you haven't taken it yet to let me know if you're able to attend in person, and if not, if you'd like us to set up Zoom. And then following that, our next web-based learning opportunity won't be until October. So again, thank you to Sarah and Michael for the presentations on your Safe States Conference presentations. I had a couple other people that are from our network who are presenting at Safe States and weren't able to present today, but had offered maybe doing something in the future. And so if that is something that this group is interested in, that's something that I can set up. And I think it's just a nice opportunity to learn about what we're doing in our own states and with our own work. Are there any final thoughts or questions from the group? And if not, we can end a couple minutes early. Okay, well, thank you all for joining. I'm looking forward to seeing some of you next week in person. If you are going to Charleston, safe travels. And if not, let me know if you want to be connected or if you're able to make a Zoom link if I set that up for the in-person meeting. So thanks so much and enjoy the rest of your Monday. Bye, everyone.